and welcome to this second webinar of the Thematic Working Group on Action on Accountability and Anti-Corruption for SDGs. This is a thematic working group at Health Systems Global. Many of you are members and familiar with the group, the different groups, and I hope after this webinar I can entice you to join the group. The group is co-led by several chairs. I'm one of those, and we have a lot of opportunities for involvement in various capacities. So what you could see on the screen is the link. And even if you lose it, if you go on the Health Systems Global website, you'll be able to find how to join the group. So come and join us. We're going to have an interesting session at the symposium at the Bogota conference, and which is going to be dedicated to anti-corruption solutions. So without further ado, I would like to proceed and invite our speakers. So we're going to today to talk about the cost of corruption. This is something that often remains unsaid, and very often we don't have the data. That's one of the few projects which shows empirically the direct and indirect costs and impact of corruption, both on users and end users when they seek care, but also on the health system. And it's a very important webinar for us all. The speakers are, we'll start with Dr. Mihaly Fazekas. He's the director of the Government Transparency Institute at Hungary, and he's assistant professor at the Central European University, School of Public Policy in Austria. The next speaker will be, who is also one of the co-authors on the report, is Olena Nikulina. She's a data analyst working at the Government Transparency Institute at Hungary. We have very soon to join Peter Mbevesa, who is a principal inspectorate officer at the government of Uganda. Peter has been a very important part of this research, advising and shaping the intermediary research, really bringing the government perspective to all this, the perspective of somebody who is trying to manage these challenges. Finally, we're going to have comments and discussion points from Dr. Eleanor Hutchinson, who is associate professor in anthropology and health systems at the London School of Hygiene and Tropical Medicine. She has been involved in Uganda for many years and also working in the field of anti-corruption. So without further ado, we're going to proceed with the presentations. But before that, I would like to acknowledge the support of GIZ for this research. It's very important because we see very few funding streams coming towards this area of studies. And it's important as this is very relevant to policy and practice. So the team in Uganda, led by Einar Vogt, were very instrumental to this, and as well as I said, the government of Uganda. So without further ado, I would like to invite our first speaker, Mihaly. And please keep your questions for the end. If you have any questions, burning questions, just put them in the chat. We're going to go back and review what's submitted. So thank you very much. Over to you, Mihaly.
Great. Thanks a lot, Dina. Thanks a lot for the colleagues for organizing this. And because this is a study which has been recently published, let me quickly drop the link to it on the chat so that people can see it and observe it. Now, as Dina mentioned, so this is a collaboration between quite a few people, so including GIZ and the government of Uganda, but also collaboration among quite a few people who worked on this study. So that includes Isabel Adam, that includes Olena, who is going to talk after me, but also Dina and Eleanor have also contributed. We also have Elizabeth David-Barrett and Monica Kira, and then Karin Pfeiffer. So really you can see that was quite an intensive data collection exercise, and a lot of things have happened with the data, with the analysis, and also the policy aspects of all of this. So hence the large group. Now we believe that this is specific to the Ugandan context, very much rooted in the local context, but many of the methodologies, many of the findings, many of the challenges we faced are interesting for other countries, interesting for our listeners who might face similar challenges in other countries. So you might be able to learn and do lessons. We quickly talk about the background and our methodology, and most of what Olena and I will present will focus on our findings and recommendations or policy options, if you like. So the study, which I posted the link in the chat. So the study aimed at estimating the prevalence, so the frequency of occurrence of corruption and its costs. And as Dina mentioned in the introductory verse, that's very important because I guess by and large, there's a consensus that corruption is a bad thing. So we don't want much of it, but really how much of it we can tolerate and how much we should invest into fighting or mitigating or limiting corruption. Well, this is at least partially a financial question, right? So if corruption is widespread but doesn't cost us much, then maybe we should not invest heavily in curbing corruption. Whereas if we have corruption, which is very costly for health systems, but for other government activities, then there is a lot stronger arguments for investing in anti-corruption. Now, this is narrow financial calculus, right? So, of course, there are moral and other aspects of this. So I have led this project, but really the heavy work has been done by the team. So I'm very happy to see Olena's contribution, and then Dina and Eleanor will chip in, and unfortunately not everyone could join us today. So first, the methodology, and this is probably the part which applies to a wider range of countries. So measuring the cost of corruption is tricky and difficult for a number of reasons. One is that corruption is not a thing. It's not one kind of behavior. It's not one kind of situation. Rather, corruption is a term for labeling very different sets of behaviors with different actors, different social relations, underlying norms, underlying collective action capacity, what have you. So that really is means, or that really implies that the study had to look at a number of things, identify corrupt practices, and then measure their diverse costs, right? So to make this tractable, we looked at 4 different types of corruption, or dimensions of corruption, I would say. So naturally, low-level versus high-level corruption, this is something we differentiated among. So others call it petty corruption versus grand corruption. We also looked at corruption, the nature of the corrupt activities, whether it's transactional, so I give you a bribe and you get me an extra service back, or there are non-transactional forms like stealing medicine. Then there are different cost types attached to these corruption types. So the costs can be direct or indirect, right? So if someone is unable to pay a bribe, and as a result, that person doesn't get treatment or get substandard treatment, that's a direct cost, of course. But then often we have indirect costs which propagate through many years, which have wider implications, not just for the individual, but say for markets or wider sets of people, wider sets of groups. So these indirect costs are typically bigger, more relevant, and longer lasting. But of course, because they are few steps removed from the corrupt act itself, they are harder to measure. And then finally, we have cost forms, financial, so bribe can be a bag of cash, but also in-kind costs. So it's, you are forced to help teachers in the teacher's garden in return for getting a better grade, right? It's no money gets exchanged, but it's clear. The actors know that, I'm helping in the weekend on the garden so that the teacher gives a better grade. So what kind of practices did we see? And then these will be quickly shown with concrete results. Concrete numbers. So the diversity of corruption reflects in the healthcare context specifically as well. So we have this very high level corruption in the policymaking process, or the highest level of the regulation of healthcare. So we can think about the regulatory framework, the legal framework, which can be captured by special interests, classic drugs companies, bribing their way through, or whichever influence they find to get the right laws, right, which benefits their interest at the expense of the budget or the patients. Now, procurement is still typically considered as a domain of grand corruption, but it's moving away from the regulatory agency, from the parliament, and looking at policy implementation, but still big amounts of money involved. You can think about building a hospital, buying machinery, or drug purchases and provision of those drugs. And then going further down in the policy implementation chain, we have recruitment of staff and corruption around that, like accepting or providing fake degrees, or bribing for a particular recognition of different documents and papers. Then we can look further at corruption in the finance and control system. So the budget is allocated, money never arrives, or the money arrives, but then it's being spent on something totally different than originally intended. And then at healthcare facilities, so if you like, as the street level bureaucrats where a service is being delivered, then we have all sorts of informal payments, bribery, we have absenteeism, the doctor is not where he or she is supposed to be, so on and so forth. Then moving further down or further on in the implementation process, we have the medical products, so drugs, the medicines being stolen or replaced by substandard versions. Then we have presenteeism, right? So that's a different thing from absenteeism. So the doctor is there, the nurse is there, but then just not working, right? It's doing something else, or frequently what happens, the doctor is in the public hospital, but treating private clients for quite a different fee. So from this list, you can see we were trying to track very different activities at very different kinds of corrupt transactions or corrupt activities, and then the costs are also very diverse. So thankfully, we could transfer most of these costs into Ugandan shillings, so we could add them up. But just to make it very clear, we don't think they are equal and they are the same, right? So just because we can add mathematically up their costs and get to some big numbers, that doesn't mean that the solutions or the impacts of these different kinds of corruption are the same, right? So it's very important that while we aggregate at the very end, we very much remain aware of this diversity of practices and diversity of types of cost. So how did we try to track many of these things? And arguably, our account is heavily a lower bound estimate, right? So you will see that we have large numbers, but probably they are underestimations. And the reason is that we couldn't get data for everything, or especially for indirect effects. Even if we have data, it's uncertain to attribute certain costs to very specific corrupt activities. Anyway, so what we have employed is a mixed, comprehensive set of methodologies. We have a tried and trusted methodology looking at corruption risks in public procurement and the associated pricing, the associated price increases in public tenders. So that's something we have applied in Uganda, but also a large number of countries. Some of you, if you're interested, you can see close to 30 countries with this methodology. Is the corruption cost tracker, and this is a project we developed originally together with the IMF. Now, we also run a reasonably large household survey of public service users. So about 1,600 households responded to this survey. And we specifically surveyed people who have had some experience with public service users for this study. That's healthcare. They also did a range of interviews, expert interviews, both at the center of government, so national level policymakers and experts, and practitioners, public officials running a hospital or running a clinic, or also NGOs outside of the system, right? So TI Uganda, for example. We also analyzed government records where we could, and then we did a desk review, in particular prior surveys of bribery. Very quickly, some findings, and I will pass on the baton to Olena in a second. So when you look at our sample, so we surveyed on a number of public services, not just healthcare, but of our sample, 80% of the households had some level of interaction with the healthcare sector recently, of course, not in general. And of these 80%, 20% positively responded to having paid the bribe or other in-kind forms of bribery, so working for the public official or giving a gift, what have you. So the average value of these bribes was 24 euros or 100,000 Ugandan shillings, and the median size was much less. So you can see that there are a few very high value bribes, and then most of them are on the left-hand side, so less smaller value bribes. Now, not large, but nevertheless a non-negligible amount of respondents had some negative consequence from paying bribes, so had to cut expenses or borrow, or even were unable to pay the bribe. Now, we have also quite a bit of variation in the location, so the services provided, the service provision location, and bribery. Some areas like a national referral hospital or health center too, we have found very little bribery as opposed to other health centers and general hospitals. Also, bribery rates vary quite a bit by illness. So you could look at, quite as expected, long-term physical condition associated with the highest rate of bribery, serious condition, as opposed to flu and cold, which are more or ordinary sicknesses. So really, bribery was considerably lower. Also, we have run some regression analysis, looking at the predictors of bribery, and we see like poverty is a positive, by the positive influence on the likelihood of giving a bribe. Also, there were strong regional differences. So compared to the center, Kampala, we had eastern and western regions, and then eastern had a much less likelihood of paying a bribe. Absenteeism was indirectly assessed, right? So we didn't survey doctors asking them whether they showed up to work. Rather, we look at patients who observed that there was no doctor, even though the doctor should have been there. And then, so healthcare workers, a doctor or a nurse. So that was 17% of our sample who had some contact with healthcare. And then most of these observations of absenteeism related to 1 or 2 occasions over a 6-month period, but there were some cases of quite frequent instances of absenteeism. Let me pass on to Olena, and I will take it back for a last few words at the end.
Thanks a lot. I think I can share my screen as well, if it's convenient, or you will just click. Okay. Second. You probably can see it, right? Okay, so we are moving to the corruption costs.
Yes, Olena, we can see.
Sorry?
Confirming that we can see it.
Ah, nice, thank you. And the aggregated, the big numbers that we found is 157 million euro, or more than 672 billion shillings. We should be mindful that this number should be considered as lower bound estimate, as Mihaly already mentioned, because while secondary evidence and evidence collected in this research shed light on many interesting cases of corruption and certainly corruption trends, it cannot capture everything, every cost borne by government or citizens or society at large. So it's a low bound estimate. Still, it's a significant part of annual government spending on healthcare. For instance, comparing it to 2019 figure, it's more than 1/4 of the spending. So it allows us to make a conclusion that if corruption would be eliminated, it can help to increase the healthcare budget significantly and consequentially increase quality of healthcare products, healthcare services, and also payment for healthcare workers in Uganda, which is not sufficient as for now. This table shows us a breakdown of costs by main categories. The largest category is loss of salaries to healthcare workers paid despite their absence. We should understand that that's partly, so mainly it's a cost for public budget in the form of wages that were paid, but workers didn't really show up at work. But it also poses certain social and individual costs when, for instance, citizens come to the hospital and can't find the doctor. He or she might just be undiagnosed, untreated, and that will result in worsening healthcare state of this person, for instance. Also, another big cost is cost of bribing healthcare provider. We estimate it to be almost 33 million euros annually. And another large cost is loss of treatment due to not affording to bribe healthcare worker. We also have the cost of procurement corruption in the healthcare sector, and that's a bit more than 810,000 euros. But we should be mindful that that's a really low bound estimate. We only included in this figure the cost of corruption in the procurement that have a procurement category related to healthcare, while we know that healthcare sector actors might procure other stuff, for instance, construction, renovations, some, I don't know, stationery, hygienic products. So here we only included healthcare related products, and that's a part of the larger cost that exists. Also, our study, we're looking at some costs that we were not able to identify and measure. Mainly it's drugs pilferage. Drugs theft pose a lot of costs for citizens, society, and public budgets. For instance, when citizen cannot get the free of charge medicine in the hospital, he or she should go and buy it somewhere from the private provider. Sometimes private provider can give citizens medicines of lower quality. Also, it might happen that citizens simply do not have money to buy drugs from private providers, and he or she just end up worsening their health because they cannot get medicines. Also, that's a big problem in a sense that generally creates an boosts market for substandard and falsified drugs. And while it's an important cost, like it's an important group of costs, we're not able to put the precise number on it because of the lack of the data and the sensitivity of the topic. Like we're not able to simply survey healthcare workers and ask them how many drugs they or their colleagues stolen, because they would not answer to us. Our study also identified different corruption forms and consequential corruption costs that are important to mention and maybe to explore later. We're not able to put numbers on them for now, but they are certainly important. That's different forms of corruption in healthcare workforce recruitment, for instance, bribery for hiring, forgery of documents, when doctors buy forged documents and start working in clinics without qualifications, and political interference in hiring process. That's also use of public healthcare facilities for the provision of private healthcare services, and corruption in provision of licenses to pharmacies. And we are moving to corruption drivers and policy options, and I return the show to Mishi. Do you want to share the screen, or I just can do?
I take it back, I guess.
Okay.
Now that is our habit.
I'm spoiling the.
So anyway, so as you can see, we had quite a few different strands to this research, and then now we jump to understanding the drivers of these big numbers, and then correspondingly looking at the different policy options linked to them. A lot of this is not coming from randomized control trials or what have you, but really our qualitative understanding of what's going on, and a few of the correlations and relationships in our quantitative data. Now, to organize our thinking around drivers and policy options, we again started off by recognizing the diverse social relations and diverse functionalities or roles corruption plays in different parts of the healthcare system in Uganda. So we basically organized our thinking around three not mutually exclusive, but still different strands of understanding corruption. So the one group of factors and policy prescriptions follow from the logic of principal agent theories. The second group revolve around understanding corruption as a collective action problem, a collective action dilemma. And finally, we also looked at corruption as a solution to functional problems. So where it fulfills certain governance or other roles. So each of these three will have a bunch of drivers identified, attached to it, and then some policy options built on this understanding of the drivers. I absolutely have no time to go over all of what we have found, so just highlight one notable example for each group. So in terms of corruption drivers under the heading of principal agent theories, one frequently heard and identified problem was the weak capacity and resources of auditors, inspectors, and regulators. And if you look at the amounts of costs corruption impose on society and the budget, then that's, it's a clear case for a cost-benefit analysis. But of course, it's one thing to identify this problem. It's a different thing to see what to do about it. And then one thing is, following on this cost-benefit logic, yes, we need more resources available for auditors and inspectors. But also there were quite a few cases when we identified problems with incentives of the monitors and weaknesses in the institutional setup of the monitors themselves. So it's partially about improving resources for these organizations, partially about making them independent and making their incentives align with public interest. The second set of corruption drivers we looked at fall under the collective action problem understanding of corruption. And here one key factor we identified is the lack of or very weak oversight of each stage of the medicine distribution process, in particular oversight by those who should receive these services. And here one of the standard prescriptions or solutions is to improve data transparency and monitoring of the full procurement cycle. So from starting the tender to post-award, so actually delivery of the drugs and then distribution of the drugs, right? And here you can rely on civil society, and there are quite a few active organizations from TI or the Africa Freedom of Information Center who have the capacity and ability to you know, in conjunction with others, fulfill these monitoring roles if the data is there, if the data is usable, and if they get access to really look at the details and hold and the actors to account. And finally, corruption as a problem-solving functionality. So corruption helps, interestingly, helps to maintain at least some supply of healthcare staff, in particular doctors, in rural areas. So in the cases when facilities are poor, working conditions are poor. So for example, it's very hard for doctors to find adequate accommodation in the countryside, then corruption is a way to make these jobs more attractive. Of course, we don't like corruption, but we understand the functionality it fulfills. So in following from this logic and understanding, investing in accommodation of healthcare workers is going to contribute to solve the problem of corruption and improving you know, payment and the whole package for doctors, especially moving from cities to countryside, rural areas. That's a major recommendation we made. And then naturally, you know, in way of concluding, as good academics, we repeat our failings and reiterate how many things we should have done if we had more time and more resources. So we identified some non-measurable costs, which nevertheless, you know, probably are very important. You know, a low quality of procured goods, low quality of medicine, for example. This is something we basically could not study, but definitely is important, and many people on this call know how important it is. And then just to reiterate, we have come to large numbers, right? 1/4 of the budget lost to corruption one way or another, but this certainly is a lower bound estimate, in particular looking at the longer term effects, like think about, you know, not getting treatment once or twice, or getting substandard treatment once or twice is a quite different thing from really developing chronic diseases and then, you know, 10 years or 20 years down the line not being able to work, right? So the sort of longer term labor market implications, productivity implications are enormous, but it's very hard. They're very hard to measure, not just because of data, but because these impact mechanisms are very complex. A lot of things happening between you as a child not getting the right treatment, and then as a young adult, as a, you know, late 20s, starting to have a lot of sick days off work and not being able to work properly. So let me stop here and thank you for your attention, and then pass on and over to Eleanor.
Before moving with Eleanor, I just wanted to check that Peter is not here. Is he in the wrong? I'm just checking. You don't see Peter somewhere?
No.
In that case, yes, maybe Eleanor, we move with you and you could give your comments within 5 minutes. This is just to everybody. If you have any questions already or things you would like to discuss, please put them in the chat, or because it's not so many of us, we will have the opportunity to actually ask them. And maybe that's better, because we know that a lot of people wanted to join. We had huge amount of people registered, but everybody is busy. So people listen to the recording so they can hear your question instead of in the chat. So thank you. Over to you.
Thank you very much, Dina. Thank you very much, Mihaly and Olena. As an anthropologist, I'm always amazingly impressed when we manage to put sort of figures and numbers onto corruption. And I appreciate it's incredibly important to have those figures as a way of sort of arguing with governments that tackling corruption is a really effective way of investing in health systems. So just to give you some background, I'm an anthropologist. I've been working since 2011 in medicine markets and with frontline healthcare providers in Uganda. So my comments are really going to be in relation to that. When I come to corruption, we know that data is really the first step. You know, it allows corruption to be seen and to be understood. But for all of us who are interested in health systems, we want to, you know, use this to sort of tackle and improve access to care and make improvements in the health system. So I think it's really important that we think about the different ways in which we can sort of tackle healthcare corruption. I think in particular, this sort of problem-solving idea. So a couple of points about the overall report. I think it's really important that we've had this Robin Hood thesis about informal payments challenged once again. This idea that informal payments are in some ways gathered from the rich and used, you know, that health workers will tackle wealthy people and will try and get informal payments for them in order to bolster the health system if it's underfunded, for example. We've seen in many reports that this has been challenged. This report also challenges that. And I think it would be nice if we could put to bed the sort of Robin Hood thesis of informal payments and appreciate that actually it's the poor who tend to make more of these payments and it hits them harder. They're very aggressive. Second point, I think, is to really stress how corruption occurs in a context in which there are insufficient government funds, in which we're worried in Uganda these government funds actually seem to be falling rather than rising as a percentage of the money that the government is investing in the country as a whole. So we know that corruption exacerbates a difficult situation. We can see with this report really clearly. We now have, you know, a figure that we can put on that, and I appreciate that it is probably an underestimate in terms of how much corruption costs. But it also makes it very difficult to see corruption when we have an underfunded health system. So we don't know when people go into health centres whether there aren't enough medicines in the health centre because they've been pilfered and taken by health workers, or because those medicines just never arrived in the first place. And in the district that I've been working in most recently in Uganda, we know that for months and months and months, no medicines have been received at the district level in order to go into the health centres 2s, and into the health centre 3s in particular. There's a different way in which medicines get into hospitals in Uganda. And with that in mind, I think there's something interesting also that we could say about community health workers, because there doesn't seem to be bribery from this report anyway around community health workers. And I don't know if, you know, it'd be interesting to discuss with the attendees whether anyone has seen any work that's been done on community health workers and bribery, even if it's to say that actually it doesn't really happen at this level. And research that I was involved in during COVID-19, where we interviewed some community health workers who are part of the Living Goods project, where they're allowed to sell medicines for, you know, for a very low cost in their communities. Those health workers didn't put their prices up during COVID, during the lockdowns, when all the drug shops were putting up their prices and when medicines weren't really available in the health system proper. So that could be that there's something very interesting going on there. And that if you're looking for ways in which to provide more medicines to people and bypass corruption, that actually maybe investing more or enabling more medicines to be distributed between community health workers is a really effective way to do that. I've only got a minute left. In terms of training citizens so that they can call health workers to account, we know that organizations like CHERD are already doing that. I think we always need to raise the fact that maybe citizens don't have the power to call their health workers to account, that maybe it's very difficult when you've only got one person working in a health centre too, that actually to criticize that person is also to put yourself at risk, you know, whether you could then go to them for health and for treatment. And I think finally, in terms of thinking about how many health workers there actually are in the Ugandan health system, in the medicine retail sector that I work in the drug shops, there are many nurses who are trained who actually find it very difficult to get jobs in the formal health system. And there seems to be a mix of inefficiencies and corruption around human resources in Uganda. And if those could be tackled again, what you might see are more health workers going into the health system itself. And then that could manage things like sort of overwork and burnout that may push health workers out of the system and into being absent. And I have 8 seconds left, so I'm going to actually stop early. Thank you very much. Great presentation.
Thank you very much. Thank you. This was brilliant. Wonderful presentations. So I don't see anybody asking questions. However, I'm burning to ask my question first. Take this opportunity. So I think the figures are extremely powerful. The reasons already you said, it's really everybody's trying to quantify what is lost to corruption, because that's that could trigger political action, but also could influence how money are invested and what parts of the system, what should be strengthened. So that's really important, the quantification. So my question to you is, was there any way to separate what is the burden of these sort of resources lost to primary healthcare in particular? I know that you looked at different levels of facilities, but one problem with primary healthcare that we have is that people can obtain primary healthcare in hospitals. So it's really difficult to separate. So even if they say this was at hospital level, this was not, but generally from the qualitative, from your sort of overall data, can you say something about the burden, particularly in primary healthcare?
I don't know, Olena, if you want to come in. I don't see a clear way of looking at that, because indeed we have the facility, which is easily observable, so, but it's not fully mapping onto primary or not healthcare, and also the type of illness. I mean, that's again, I don't know. So that is a hard one. I don't know, Olena, if you would have any ideas to that.
Yeah, I would say the same.
It's also a question of numbers, right? So primary healthcare, the first point of contact, I mean, this is where the most interactions are, right? So in a survey, that's where we can get more reliable numbers, right? And once you get to smaller groups, your statistical power quickly, even if 1,600 respondents is a pretty big sample, it's not huge.
I think my observation is that in future surveys, I think, and that's something that we really found out in the past year, there is a huge international interest precisely in improving efficiency in primary healthcare. So if there is any way to really map, so you had maternal care, but maybe if we say antenatal care, we know that happens at primary healthcare, so we can triangulate and kind of deduct, because most countries don't have a separate budget line for primary healthcare, they have programs, so it's really difficult, but I'm saying challenging methodologically. So it made me think, how do we do it? So if you're starting a survey now, would you do it per type of facility or type of service? That's just like, what do you think?
Yeah, I think the type of service would be super interesting to look at, because, you know, we thought facilities and the illnesses would be the main dimensions, but they don't fully determine what kind of service. And again, I think we've seen this, right? The more serious the illness is, the higher the bribes, the frequency and the amounts. So I could also imagine that goes by the complexity of the intervention, the complexity of the service, right? So that might be quite an interesting thing. And if you remember one of the earlier slides, so I shown that the average bribe is much higher than the median. And those of us who do stats, it means that there are outliers, very high value bribes, a few of them, and a lot of small value ones, right? So the distribution is very long, and understanding that long tail, so those few very high value bribes, that indeed is of particular interest, because it's a different nature, right? So the type of service, the type of intervention, I think could be one interesting variable in this.
So let's open to everybody. I would like to invite everybody to ask questions if you have any specific questions to our presenters. And just jump in. See in the chat. I don't see any questions. So perhaps I was thinking that you could maybe Olena and Mihaly, you could comment on some of the things that Eleanor said. So for example, the fact that it seems like the community health workers, we don't see this there, or generally some of the distributional issues around who pays by socioeconomic status. Maybe you could comment on that. Was you expected?
Yeah, no, and then before that, I think I found one point very interesting, is that if you have a generally underfunded healthcare system, it's very hard to differentiate between the drug is not there because someone stole it on the way, or it was just never enough money in the budget to send the drugs to, you know, XYZ place. And I think this is a tricky one, right? And then probably it's intertwined, right? So there was anyways few drugs or, little, machinery available to start with, but even that is stolen to, in some cases, spectacular proportions on the way. So problems accumulate, right? They add on top of each other, and it make the healthcare quality and the burden of disease much worse, because you start from something very low and then you make it even worse. So I think that's a tricky one. And in our survey, we try to at least differentiate it as much as users can observe, right? So we really asked, have you experienced when the doctor was not there, when it was supposed to be there, right? So, but then you rely on the assessment of the respondent to know when the doctor was supposed to be there, but maybe they just don't know correctly, right? And the doctor,
I mean, we were exactly, that was our thinking. Eleanor and I were quite surprised that the absenteeism rate is quite low. In Nigeria, it's much higher. It's in other countries, but maybe, so I wonder whether maybe something like that, what you're just saying now, people have low expectations. They wait a long time. They don't know what's happening. And maybe the reporting, or maybe there is another way to capture this.
Yeah, so ideally we would have liked to match administrative records where doctors would have should have been, right, and then whether the client, the patients actually observed doctors being there. That's the correct way to do. But even the administrative records were not good enough for this sort of analysis, because we just, after a few interviews, it became clear that for drugs as well as for staff, the records are not, complete, not reliable enough. But yeah, if people don't expect doctors to be there, they won't say it's, they should be there and they're not there. They're just not there, and that's it. You don't even try. I mean, that's the kind of vicious circle, right? If the doctor you tried a few times and was not there, like, you don't wait there for a few hours the next time.
I think there's also another issue with that when there aren't enough medicines in the health system. We know in Uganda, and I'm sure in other countries as well, that when the medicines eventually do arrive, people go to collect them to then have them at home, which is entirely logical. If you're not sure when the medicines are going to be at the facility, that you go and do that. But we also have had accounts of politically powerful local people going to the health centre and making demands that they can take the medicines out of the health centre and store them at their homes to distribute them amongst their people, when they get sick. And interestingly, some work I did on rapid diagnostic tests for malaria became really useful for the health workers, because instead of going in and saying, I've got a fever, I need some malaria medicine, people would go in and be tested and would only get access to that medicine if they tested positive for malaria. So it stopped for, I don't know how long it worked for, but it stopped for a certain amount of time, people being able to hoard malaria medicines at home. It was a sort of interesting unintended consequence of changes in care.
Interesting. So any questions from our attendees? If you have any questions, just jump in. One thing I wanted to get your reflections in the final few minutes of the seminar around methodology, because that's really, I think the cost, this is one of the most policy relevant studies I've ever seen. And this is what people are asking us in Nigeria. This is what we're asking in Zambia, in a lot of countries where they really, that's the answer people are still searching for, how much it costs. And it's very powerful, especially if you try to disaggregate by different types and a little bit has a bigger, larger sample. But methodologically, I'm just wondering what can be done, and you could just maybe give your recommendations. If we talk about routine health systems, what can be done, given what we learned? How can we capture these costs on a maybe more ongoing basis?
So that's a tricky one, right? Because calculating these costs takes also resources, right? So, I mean, we could do a comprehensive study thanks to GIZ funding, but making this like an annual or biannual analysis, that's a different ballgame. But indeed, especially if there are policy reforms and you want to see if they work, you would want these, at least elements of these studies repeated. And then I think there are two major avenues at the very least. One is we use administrative data, which are generated for purposes other than this study, right? So you have procurement data, you have some other HR records which are a bit more reliable. So if you have reliable administrative systems which produce these data sets, then checking on some of these indicators are relatively straightforward, right? Relatively standard. As you repeat them, they become cheaper and quicker. Now, the second thing is surveys, right? So running a survey just on the cost of corruption is luxury, and we're happy to be able to do it, but it's unlikely that we will have many such surveys in the future. But there are regular household surveys, there are regular surveys on citizens' opinion and trust in the government. So inserting just a few questions, which we thought were particularly relevant and powerful, that's again very cheap, right? So once you run a survey for 25 minutes, adding 2 more questions, it makes you an extra 1 minute. So these are the sorts of easy wins, which I think our study could contribute to, like at least some of these, these 4 or 5 questions, big maximum, included in the regular, national integrity survey or the, whatever household survey opinion poll, and then you can track them, right? And that I think is important. And as you say, you can improve on some of these things, right? So we miss the primary care versus not sort of dimension. This is something we can fix going forward.
Brilliant. I know that some countries have experimented with collecting data. It was not on services, but it was on payment for drugs, using crowdsourcing, using social media sort of people. They have a platform, even from a normal phone, they can send information, how much they paid. This was done years ago in Bangladesh. What is your opinion about those? And obviously you have to have an algorithm which calculates things, but what is your opinion? Do we see good examples of that, or still quite vertical in the band?
Crowdsourcing this, yes. I mean, there is the famous Indian example, right? I paid the bribe, right? So that's running for God knows how many years, has been, people try to emulate it.
Is this useful? And can you actually automate the analysis? That's what I'm thinking. I don't know many examples.
So it can be useful in different ways. So one way of this is the collective action dilemma behind corruption. So those who pay, they realize, oh, others are also asked, and then why on earth do we have to pay so much for birth or an operation, what have you? So sort of low, if you like, the information asymmetry gets a bit balanced out, and now people can see what the prices are, what others are paying, and there have been examples that I paid the bribe, and the information based on that mobilized people, right, and made it harder for excessive demands, right? So these sorts of mobilization won't solve systemic problems. Doctors are underpaid or what have you, but then at least cut the extremes when someone just cannot afford because the bribe is outrageously expensive. So there is this mobilization aspect. If you want to use the data and base regular assessment on it, that's a more tricky one, right? Because technically speaking, so there is a sample selection problem, like whether people respond to this or report on these portals, especially in places where there's no internet, they will not, right? Because this is an online portal. So your sample is tweaked to those who can and willing to report. But within those limits, you can track, right? I mean, you can. There are a few examples from India where district managers were basically going after these people who had a lot of reports on them. And then there was this tax collector who had last week 2 reports on how much he or she demanded, and then, well, you shouldn't ask for bribes. And then the supervisor of this tax collector actually, went and asked inconvenient questions, right? So you can use it for flagging up some problems, and you can look at some trends, and within these there's limitations of self-selection into this, you can really use it for some monitoring tasks.
Thank you. And but I think this takes us to the other problem that I think, Eleanor, you could say something about this, whether people want to know, because if you know, you have to act on it. And we see situations where policymakers know that this is happening, but that's the only way to sustain and to persuade doctors to stay. And also, if people, what we see in some cases where people share information about particular providers charging more, this only is helpful if people can go to another facility nearby. But if they're in a rural area where there is only one facility, what do we do? Is it effective? So I kind of feel very often, and that has been a problem in countries in Eastern Europe, where there is information on the level but of payment, but policymakers almost ignore it. So this is now we see happening in a lot of other settings where resources are low. And somebody would, there is now a report for parts of the European Union where the same situation is happening. We just saw a paper published on the scale of informal payments in the European Union, which is quite eye-opening in health affairs. So I would like to give the final maybe word to Eleanor, just to say, given this sort of contradictory pressures, on one hand, we need to know, and everybody wants to know how much it costs, because that would really target how to target investment, how to reduce this, and instead create incentives for attracting this money in the formal health system. But at the same time, you need the very often corruption is the glue that moves the system, the wheels of the system. So how do we move forward on that?
So maybe we could end on a positive note,
Yeah.
which is we hope that there will be more investment in health systems. I think the Ugandan health system is crying out for further investment, and we absolutely need that. Currently the government is only procuring around 50% of the essential medicines needed for the country, which isn't enough. But if we think about, okay, so going forward, there will be more and more investment in health systems. That's what we're expecting. That's what we're hoping. And I think that anti-corruption is going to have to be mainstreamed within that. So that as there are more medicines, and we can then make sense of the fact that if medicines aren't reaching people, that then it is something about the irregularities and something about the corruption that is then stopping the medicines getting to the people who actually need them. We're going to be able to see that more easily. And, convincing governments, as you're spending your more money, tackle anti-corruption, because it will enable the money that you have to go further and to be spent better. So I think that's the case. In terms, and just finally, just in terms of where do you go if you find out that someone is charging more? I think underpinning that is somehow the myth of choice, that people have choice about, I'm not going to go here, I'm going to go there, almost as if you're sort of doing your shopping for clothes. And healthcare just isn't like that. It's completely different.
Thank you very much, everybody. Finishing exactly on time. This has been a fascinating seminar, and thank you for all these reflections and being with us today. We hope via the thematic working group to promote the report. I think it's very important that it reaches more people, and promote the recording of this webinar. And I would like to again invite everybody to join the group. There will be a lot of opportunities to get engaged, and there are a lot of initiatives, funding opportunities, and opportunities to really think what it means to tackle corruption. And I think I really take your point, Eleanor, that ultimately there is not enough money in these systems, and this triggers corruption. But at the same time, we see countries that have expanded coverage, they've introduced insurance system or improved their taxation-based systems, and we still have increase in corruption. So we have to do both. I think it's really important lesson and note to finish on. Thank you very much, everybody, and have a great day.
Thank you. Bye-bye.
Thanks very much.
Bye.
Bye-bye.
Bye.